Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging. We want to help you be more successful. And our guest today is Dr. Richard Milani. He's Chief Clinical Innovation Officer at Sutter Health. Welcome, Richard.
Thanks for having me, John. It's great to be here with you.
Yeah, excited to dive in. You guys are doing some really interesting things at Sutter Health, some unique things which we often don't get on this program. There's a lot of consistency between organizations, but before we dive into that, tell us a little bit about yourself and Sutter Health.
Sure. I'm a physician. I've had I guess about a 15-year background in digital health. My focus has been primarily around combining technology with virtual care delivery and managing chronic diseases, and we'll talk a little bit about that when we get to Sutter Sync. I had spent part of my career at Ochsner in New Orleans, and then was fortunate enough to come out west and be a part of this great healthcare team at Sutter Health.
That's awesome. Ochsner had one of those first device locations. I imagine you were part of that. You were early in that adoption of devices, I think, if I remember
Yeah, it
right.
was that was one of our creations. We created the O Bar in 2014.
Yeah, that's it.
That came out of my shop, so that was really that's been a real fun experience.
Amazing. Yeah, I learned that deeply. We held a health IT conference in New Orleans, and of course, we had to involve Oshner. So, but you're doing some really interesting things. You mentioned Sutter Sync. You recently announced it. Talk about it. What is Sutter Sync and what's involved with it?
Well, let's start with the problem before the solution without making this too lengthy a conversation. But
Sure.
um, if you look at chronic disease care, whether it's hypertension, diabetes, COPD, heart failure, at a national level, actually, truthfully, at an international level, we do not do help. We, being the healthcare system across the country and the world, do not do a good job of managing it. And so, if you look at the most common chronic disease, say in the world and in the United States, it's high blood pressure. The control rate's only 23%. And moreover, each year it tends to be getting worse. Same thing with diabetes. Diabetes each year, it's under 50% control and getting worse and declining with each year. And again, the consequences of lack of control is now all the bad things that come with it, whether it's heart attacks, deaths, strokes, kidney failure, et cetera. So the fundamental concept here for us is how can we change how we deliver care for patients with these conditions that just don't go away. They're likely to have them for most of their, if not all their lives. And it requires a lot more sort of check-ins, if you will, and data collection and management than once or twice a year, which is where things are happening sort of in the standard office visit. And so that is the foundation or the concept behind Sutter Sync. So we've done this kind of work in the past. We've published our findings. We typically get 2 to 3-fold better control than standard of care for diabetes or hypertension or these sort of things. And the idea is, what if I were to collect blood pressure data from home and have it directly go to a care team that's virtualized, where we're managing this in real time? And it's not happening once or twice a year, but it's literally we're collecting data each week and we're staying on top of this so that people don't start falling out of bounds. And of course, we've done this now at Sutter in conjunction with Epic. So we're an Epic client. And Epic in Wisconsin has worked with us in building all the tools necessary to perform this inside of Epic. So all the education, all the prompts, all the nudges and so forth that we would utilize take place in Epic. And then finally, a very important piece is we actually have our own devices now. And this is actually quite important. So if you think about this, the average person in the United States the average adult in the United States already has 2 or more chronic diseases. It's not even just one anymore. And if you're going to manage that, you'd have to, let's just say from a digital perspective, you buy a digital cuff, you download the app, you have to go into the app and go into the settings and have that data somehow linked into your health records. And then you have a different device and you have to download that app and now link that into your health records. And that's perfectly fine, I think, for a lot of us to do. But let's pick on grandma or grandpa, if you will, and say, do that. Now that's a burden. It's difficult. They may not be technologically that savvy and being able to pull that off. The devices that we have now will directly go into Epic without any additional downloads. So in other words, if you have MyChart, which is the Epic patient portal, that's all you'll need. And your glucometer, your blood pressure cuff, et cetera, et cetera, et cetera, or your scale, whatever it might be, will automatically link into that without downloading more apps, none of the going into the settings and having to pull that all off. So it's really opening the door and making it easier for people, creating less friction for them to be able to enroll in programs that do this sort of thing. So Sutter Sync sort of encompasses a lot of all this in sort of one sort of management tool, which is Epic. So that is, in a very short, sort of description, what Sutter Sync's all about.
Yeah, it's interesting that you chose to do that direct integration, especially, I mean, you're in like one of the most connected tech savvy areas of the world, right? Let alone if you're in some rural area, I imagine it's even more challenging to connect, as you said, grandma and grandpa to MyChart or whatever it might be. Is that why you decided to do your own device with direct connections to Epic rather than using one of the other devices and RPM vendors on the market that, offers somewhat of a similar thing to what you're describing?
Well, it's really not similar. And so if you think about it, if I go to a vendor, once again, now you're going to have to bring in a whole nother sort of piece of hardware into the system. There's added costs there. That vendor has to make some margin on that. And so you're adding complexity and cost to the system. The idea is, how can we make this affordable? And so our devices are going to be, obviously a much lower cost, and the patient doesn't even need internet. All they need is a smart device, whether it's a tablet or a smartphone. It doesn't have to be a fancy one. It could be an old, iPhone or Android. It doesn't matter. But the point I'm making is that most individuals already own
Sure.
a telephone, a cell phone, and if most of these are not the old flip phones anymore, they're smartphones. And so that's all you need. If you just had this and you had just MyChart, which a lot of people do, and it's free, you wouldn't need anything else. And you would need additional equipment in your house to pull all this off. You're automatically tied into our system and it just works. So that was the reason. I mean, again, there's real costs involved, and the idea is, how can we make this as affordable as possible for anybody to be able to sort of jump in and be a part of this?
Yeah, that makes a lot of sense. You wanted it simple and easy, and even the other RPM vendors, it's a second screen in Epic almost. Another tab. As opposed to being able to directly integrate. It makes a lot of sense. Why did you decide to start with high blood pressure and pregnancy? What was some of the thinking there? There's so many opportunities, so many holes in healthcare. I imagine the high blood pressure is just because it's such a massive problem. Is that what you were thinking, and why you started in those two areas?
Yeah, hypertension is among the leading causes of death across the globe. And, it has among the lowest control rates. So we started with hypertension because it's pretty straightforward. It's probably where the greatest needs are. We've advanced to lipids, which launched in October. I'll talk about pregnancy in a moment, and then we'll be launching type 2 diabetes next month, and then more programs to follow. But hypertension is a critical aspect of sort of chronic disease care, and it's certainly the most prevalent chronic disease across the country. So that's why we started there. Pregnancy, what we're monitoring in pregnancy is back to hypertension again, because hypertension associated with pregnancy is a major problem. It increases maternal mortality, it increases preterm delivery, it increases even fetal harm. And we've already shown previously that diagnosing this and finding this at a sooner stage than when the next visit might take place has been shown to reduce preterm delivery and to improve both maternal and fetal outcomes. So once again, it's rooting its head in terms of what hypertension can do in terms of one's health, whether it be a young, healthy female that's developing hypertension-associated pregnancy, pregnancy-associated hypertension, excuse me, or just anybody out there with high blood pressure.
Interesting. Where do you see, Sutter Sync kind of going next? You described diabetes. Are you looking at other devices as well to help in this effort? It sounds like Sutter Sync isn't just this one-off hypertension effort. It sounds like you're moving towards a multi-device, comorbidity approach. But I'd love to hear more details. Where do you see this all going? What's the full vision?
Yeah, well, let's just talk about diabetes next, but then we'll go back to even a vision that goes beyond that. If you look nationally, I mentioned that hypertension control rate's only 23%. About two-thirds of people with, about 70% of people with diabetes also have hypertension. And if you look in reverse, the number of people with hypertension, about a third of them have diabetes. Anywhere from 27 to 30% of them will have diabetes. You know what the control rate to have both of those under control in the United States? It's 15%.
Wow.
So, and if you look at people that end up having a heart attack, having a stroke, having kidney failure, having a heart failure admission, over 95% of them during the months leading up to that event will have one of those factors out of control.
Mm.
So if we're going to really make a meaningful impact, I mean, we're in healthcare.
Yeah.
Okay. So, I mean, let's attack the biggest problems that are taking place in healthcare. If we're going to make a meaningful impact, we got to do better than a 15% control rate for people with, say, diabetes and hypertension, or diabetes and hypertension and dyslipidemia. And that's what the national rates are. So we're starting there because that's where the single biggest problems are. We'll be launching a heart failure program probably mid-year. We'll be using a device that actually can help measure body water in excess and can do that non-invasively. We're also developing with a vendor the ability to do AI-based CBT. CBT stands for cognitive behavioral therapy, and we know that there's a national shortage of mental health therapists. We know that CBT is first-line therapy for people with depression or anxiety, or even things like diabetes distress, which is anywhere from a third to 40% of people with diabetes have this, and it leads to poor control. And we know that CBT is very effective. Well, how can we scale CBT therapy? And we know that AI-delivered CBT therapy can be done very effectively, and there's appropriate boundaries and so forth in place. And so that we hope to launch as well, early parts of this year.
Yeah. What an interesting approach. I did think GLP-1s were just supposed to solve diabetes, but I'm joking, of course. But it is interesting, though, that, now, with your program, I'm sure that opens up the conversation to use GLP-1s when appropriate and other things as well. So it's awesome. You're having that proactive discussion, which many people just miss and don't even have with their care provider for whatever reason. Well, let's shift gears a little beyond Sutter Sync as well. I'd love to hear some of the other ways you're leveraging AI. Maybe let's start with radiology. What are you doing with AI and radiology?
Well, I think there's a lot of, I think everybody understands that's listening to the podcast, there's a lot of opportunity in imaging services. We've partnered with a company called ADOC, AI Doc, that is another one of these AI overlays that can help to identify problems earlier or bring it to the radiologist quicker. And they've done a lot of work in stroke, where again, they've identified the early signals of stroke and it brings it immediately to the radiologist to confirm at a sooner rate, where now therapy could be initiated at an earlier rate and so forth. So that's been a partnership that's been launched, and we're rolling this out across our system. We know that at least on a national level, there's over 370,000 sort of deaths due to sort of diagnostic errors from imaging. So the idea is to have a second set of eyes as many of these AI services can perform for imaging, being routinely evaluating and viewing all the images in conjunction with the radiologist to make sure that nothing is missed and so forth. We've also done some work back to diabetes again with AI-based cameras to do retinal exams. Now, so this is a same sort of thing. It's imaging. This is a static image of the retina. The advantage of this is that you can mobilize these cameras all over the place in primary care. We think we have 28 sites now across Sutter that has these cameras in place. And let me just explain the problem. The problem is that blindness is the leading, diabetic retinopathy is the leading cause of blindness in people under 65. Yet only about little under half of diabetics get this done routinely because it's inconvenient. You have to make an appointment with ophthalmology and you have to get your eyes dilated. You can't drive after. It's time consuming. This is a camera that you could stop by. You don't need to have your eyes dilated. So it's a non-mydriatic exam. We get an accurate picture of your retina, and it's read diagnostically by AI. This has been FDA approved. In fact, it was the first, the ability to diagnose diabetic retinopathy was the first AI approved capability without a second read by a physician through the FDA. This was years ago. So now this should be just widespread. I mean, why should it? So now I don't have to make an appointment. I could be on my way to see my primary care doc, drop by the camera, get my diabetic exam, have a result done by the time I walk in the office when I see my primary care doc. And God forbid you have a problem, but if you do, if we diagnose it early and manage it earlier, we can prevent blindness. So this is an important step forward as well.
Yeah. It's one of the coolest forms of AI, although interestingly, it started almost as maybe it's more machine learning and things, but it's one of the coolest things. And it actually is reimbursable, which is not true for a lot of the things that are happening with AI, which is great, and to your point, it pushes it down to primary care where the patient actually is seen regularly versus the ophthalmologist, which is somewhat challenging. So that's great that you've embraced it so much. And yeah, no one wants to be blind, I can't imagine. And I think people aren't informed about that risk. So I think it's great that you're proactive about that. Well, as we wrap up, we always like to end these podcasts with a little bit of career discussion, career advice. I'd love to hear, what would you say is maybe the best piece of advice that you've been given in your career?
I guess it was really honestly thinking about it, don't be afraid of left turns. And what I mean by that is that, sometimes something that's sort of out of your career plan shows up and knocks on your door and offers you an opportunity to go take sort of a left turn. It's not a bad turn. It's just a left turn. It wasn't a direction that you had planned to go, but it was an interesting opportunity. I think some of the best things that have happened to me in life were unexpected based on taking a few left turns that presented themselves along the way. And so that would be the advice that I would give anybody else, is that you will encounter some left turns in your life, and life doesn't have to be a straight line.
Yeah. I like to tell people that, I always wanted to be a blogger and podcaster when I grew up. And then they look at me and they're like, what? And I'm like, yeah, I'm just kidding. Blogging and podcasting didn't exist when I grew up. So I couldn't even have had that dream, right? Like, it was a left turn. It was like, I'm a tech guy and I discovered blogging and podcasting, and it's worked out pretty well.
Right.
Yeah. Awesome. Well, Richard, I appreciate you taking time to talk with us, to share about Sutter Sync and some of the other AI initiatives you're doing at Sutter Health. It's really insightful, and I love that you're kind of pushing things forward and proactively caring for patients. That's a really beautiful thing to see in healthcare today. So thanks so much for your time, and thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for the CIO podcast by Healthcare IT Today on your favorite podcasting applications. Thanks, Richard.
Thanks, John. Good talking to you today.